All right. Good morning, everybody. Thank you for being here. I'm really excited. Jordan and I have a really cool session for y'all. We're glad you made it out of bed this morning, and for all you folks in the Eastern Time Zone, thanks for having lunch with us. So, like I said, I'm Drake Bozek. I'm an instructor of pediatric pulmonology at the University of Iowa. And my co-moderator is Dr. Jordana Hoppe, who's an associate professor of pediatrics at Children's Hospital, Colorado. And here are our disclosures. So we have a few objectives for the workshop today. The first being to describe updates in infection-related clinical outcomes in people with CF in the Modulator era. 2, to define changes in the prevalence of typical CF pathogens in the Modulator era. And then 3, identify advantages and disadvantages of alternative modalities in infection monitoring in people with CF. So as we've heard, and I liked the slide so much from the plenary last night that I was like, oh, this is a good way to highlight this. But elexacaftor, tezacaftor, ivacaftor, or ETI, henceforth, is the most used, highly effective CFTR modulator. It was first approved in 2019 in individuals that were 12 and older. And as time has gone on, in 2021 it was available for those 6 and older. And then as of December of 2024 is available now down to 2 years old. And this encompasses, about 76% of people with cystic fibrosis are using this, and it's really been a game changer. If we look at the prevalence of CF pathogens over time, and no epidemiological CF study would be good without having, this picture. And so this is just showing from the CF patient registry report in 2023, the percentage of individuals on the vertical axis and year on the horizontal axis. And this is the typical CF pathogens. And so you can see that, Staph aureus in kind of the greenish yellow has gone up over time. Pseudomonas in blue has gone down a little bit. But at the far right, you notice this kind of dive in the numbers. Well, what happened then? So in order to better focus in on this, I just zoom in, I took that graph and zoomed in a little bit. ETI was first approved in those 12 and up in 2019. So you can see this big decline in kind of all of our typical CF pathogens. And then in 2021, in 6 years, those 6 years and older, you see further decreases. Though interestingly, Haemophilus influenza does start to tick up. I mean, there was some other stuff that happened, between 2019 and 2021. So, it's hard to say, oh, this was entirely a modulator effect. But as we've gotten further out from the pandemic, it does seem to be that these changes are persisting. So ultimately, what is the clinical impact of infection in the era of highly effective CFTR modulators? There's a wonderful session yesterday by my friend Dr. Hergenroder and my mentor Dr. Sanders that looked at pulmonary exacerbations and what to do. And I think that we'll have some interesting discussions kind of building on that in the setting of infection. So it was pointed out yesterday that severe pulmonary exacerbations, so those requiring IV antibiotics, have declined since 2019. And again, you see those 3 time points of when modulators were approved, and then, also COVID. And in addition to the reduction in the use of IV antibiotics, numerous other health outcomes have improved for people with CF, kind of as modulators have become more and more available. Though, again, I have to mention that there are still individuals that are not eligible for or do not tolerate modulator therapy. So this is because there's less pathogens, right? Well, that's a loaded question. What we've seen since the approval of ETI is that the respiratory cultures per individuals have decreased since 2019. So this is again from the patient registry in 2023, with the average number of cultures per individual kind of in the goldish orange. And you can see that in 2019, there's about 4 cultures per year per person, and that dropped down to about 2.5 per person. So you can't find what you don't look for, right? And so why aren't we looking? Easy enough, right? So I use this to highlight that fewer individuals have had 4 clinical visits per year since 2019, and the most common way that we are getting samples is from people coming to clinic. And so there's a lot happening on this, but I want you to focus on the solid lines. The green is 7 to 17-year-olds, and the blue is those that are adults or over 18. And about 60% of those 7 to 17-year-old had 4 clinic visits per year prior to modulators, and that's down to 40%. And then in adults, 40% had 4 visits per year, and that's down to 20%. So again, for whatever reason, we're not going to get into that now, but we're having people in clinic less often, and so it raises the question of how do we look for infection. So the predominantly respiratory sample type has also changed since 2019. Modulators have led to a big decrease in the amount of sputum that's being expectorated, and so oropharyngeal swabs are being used more and more and more. So to kind of sum up before we get into kind of our talks is, in this era of highly effective CFTR modulators, how do we identify infection? There's numerous ways, sputum, upper airways, BAL, and other things that are, in development like saliva, exhaled breath condensates, and serum biomarkers. But most importantly, what are the clinical implications of this? So I'm really excited. We've got 3 wonderful speakers, and then you're stuck with me again. But first we have Dr. Carl Baxter, who'll be talking about the impact of ETI on healthcare resource utilization over 3 years in longitude, a UK CF registry observational study. Following him will be Dr. Clement Wren, who will be talking about risk factors for pulmonary exacerbations in people with CF who stopped taking chronic daily therapies. We'll have Dr. Lindsay Caverly talking about the epidemiology of Pseudomonas aeruginosa before and after the 2013 infection prevention and control guidelines. And then I'll wrap up by talking about how we use shotgun metagenomics to look at oropharyngeal swabs. So with that, we'll turn the mic over to Dr. Baxter.
Great. Thank you. Thank you for the introduction, and thank you to the organisers for selecting this abstract for a presentation today. These are my disclosures. The main one is that I'm an employee of Vertex Pharmaceuticals. So today it's a great pleasure to discuss with you a UK registry study on the impact of elexacaftor, tezacaftor, ivacaftor, or ETI, on healthcare resource utilisation over 3 years in longitude, a UK CF registry observational study. So by way of introduction, ETI received its first marketing authorization in the UK in August 2020, although it was available from August 2019 through an early access program for those with severe disease. Since it is being reimbursed for all eligible people with cystic fibrosis in line with its marketing authorization. Pertinent for the discussion today is that the early access in August 2020 was for those 12 years and older with certain genotypes, and subsequently for other genotypes, and then the license was extended to those aged 6 to 11 in November 2022. So the UK CF registry is a national registry in the UK and is a comprehensive clinical data on approximately 99% of people with CF in the UK. Longitude is an ongoing retrospective registry-based cohort study evaluating real-world outcomes of ETI treatment in people with CF using data from the UK registry. We have been doing analyses in longitude for a number of years now, and we've published a number of abstracts and manuscripts of various different age cohorts and outcomes. For the discussion today, prior studies have shown that reduced healthcare resource utilization after initiating ETI, but in the UK in particular, longer-term impacts on health resource use have not been documented. Therefore, what we decided to do was an analysis of longitude, evaluating real-world outcomes of ETI treatment on healthcare resource utilization in people with CF aged 6 years and older. This was a non-interventional retrospective registry-based cohort study using data from the UK registry. As you can see from the schematic, the index date was the date of a ETI initiation, which spanned from August 19th, 2019. This was to take in the early access program in the UK through December 31st, 2023. Prior to index date, so we're looking at a 12-month baseline period, and then post-index date, what we have is 3 12-month periods equaling up to 36 months of follow-up. Looking at in a bit more detail around the study design, so the inclusion criteria you can see in the white box here. So individuals needed to have a diagnosis for CF, consent to data collection in the UK registry, initiated ETI on or after August 19th, 2019, aged at least 6 years old at index date, had at least one F508del CFTR genotype, and then in the registry they needed to have at least one annual review within the 14 months prior to index date, and at least one annual review that occurred at least 30 days after index date. We had one exclusion criterion, which was any history of lung transplant before index date. So prior to index, we had a baseline period of 12 months, and this was to capture the baseline demographics and clinical characteristics. And this data was taken from annual reviews and encounter visits that were captured in the registry. We looked post-index at a 3-year follow-up window, and this was to capture the outcomes. So we evaluated pulmonary exacerbations, which was defined by IV antibiotic treatments, and this was at home or in hospital. We looked at hospitalizations, and then we also considered medication usage. Analyses were conducted by different age cohorts, so we had ages 6 to 11 and 12 plus at index, and patients were included in the study and in the analysis until the date of censoring. So the date of censoring was either last annual review or encounter visit after an index date, ETI discontinuation, lung transplantation, death, or end of study period, which was December 31st, 2023. Here we can see the analysis cohort. So as you can see, we had 8,123 people with CF with an ETI index date on or after August 19th, 2019. We excluded 1,249 according to the eligibility criteria. This was mainly due to age. Some of them had no F508del genotype. And then the criteria to have at least one annual review in the baseline period and at least one during follow-up. And then finally, a number of individuals that had a lung transplant prior to index. This led to the full analysis cohort of 6,874, which, as you can see at the bottom, we split into the 2 different age cohorts that I mentioned earlier. Let's discuss and go through some of the demographic and clinical characteristics at baseline by age cohort. So starting at the top, just over half were male. The age at ETI initiation was just under 9 years in the 6 to 11 cohort and just under 28 years in the 12 plus cohort. Just over 63% of the 6 to 11 cohort had a prior modulator before ETI, which was around 60% in the 12 plus cohort. As regards to mutation group, the majority were homozygous F508del, so 61% in the 6 to 11 and 57.7 in the 12 plus cohort. When we look at mean ppFEV1 at baseline, in the 6 to 11 cohort, this was 90.7. As you can see and expect, there were very few of those had a baseline FEV1 of less than 40 percentage points. And in the 12 plus cohort, the mean ppFEV1 at baseline was 68.2. Here, around 16% had a ppFEV1 of less than 40 percentage points at baseline. Moving down the table, you can see the comorbidities here. These were more prevalent in the 12 plus cohort, as can be expected, apart from pancreatic insufficiency, which was highly prevalent in both age cohorts. And then finally, at the bottom, you can see the prevalence of lung infections during the 12-month baseline period. So the first outcome we're going to look at today is the pulmonary exacerbation data. And as I've mentioned, this is defined by IV antibiotic treatment at home or in hospital. So in the 6 to 11 cohort, we had a mean follow-up of 14.7 months, and the annualized pulmonary exacerbation rate declined by 54% from 0.48 to 0.22. In the 12 plus cohort, we had a mean follow-up of 29.2 months, and again, we saw a decline, this time by 63%, from 1.31 annualized rate at baseline to 0.48 during follow-up. Kind of moving down the table, when we look at the number of patients with at least one pulmonary exacerbation, this decreases in both cohorts from baseline to follow-up. And then finally, we looked at those with at least one pulmonary exacerbation, and in particular cumulative days on IV antibiotics, as well as days in hospital per pulmonary exacerbation. These all declined in both age cohorts from baseline to follow-up. Moving on to hospitalizations, here in particular, we looked at 2 groups. We looked at IV antibiotic admission to hospital, as well as non-IV antibiotic admissions to hospital. As you can see from the second row, first of all, annualized rate of IV antibiotic admissions to hospital, it declined in both cohorts, so the 6 to 11 and 12 plus, by 56 and 62% respectively. On the bottom line, you can see the annualized rate of non-IV antibiotic admissions to hospital, and this is any other hospitalization. These remain stable from baseline to follow-up, although just to note that the rate of this was really quite low anyway during the baseline period. So finally, for the outcomes, let's look at some medication usage data. So here, what we're looking at is we were particularly interested in looking at, for those patients that were taking specific medications during the baseline period, which of those continue to take them during follow-up. So here we're looking at the 6 to 11-year-old data at index, and in particular 2 years after ETI initiation. So as you can see, inhaled corticosteroids declined by 32%, hypertonic saline 13%, DNase and pancreatic enzymes decreased very slightly by 3%, and also pleasingly we saw decreases in inhaled and oral antibiotics of 45 and 18% respectively. We did also look at mannitol in this population, although the number of individuals in the 6 to 11 cohort of mannitol was less than 5, so we don't show that data here. Moving on to the cohort that was at least 12 years old at index date, and here we're looking at 3 years after ETI initiation, and this is primarily because we could have longer follow-up. We see across the board decreases in all the medications, so in inhaled corticosteroids 29%, mannitol 40%, DNase 19%, hypertonic saline 28%, pancreatic enzymes again decreased only very slightly, and then inhaled and oral antibiotics again decreased, this time by 28% and 40% respectively. So before we conclude, as with any non-interventional research, there are some strengths and limitations. So this study contains the largest ex-US data set initiated on ETI worldwide. And the outcomes of the study are consistent with other real-world data as well as the clinical trial program. As regards to limitations, so here what we focused on was change from baseline, and that was quite particular because in the UK, the uptake of ETI was very rapid, so we couldn't have a concurrent CFTR modulator naive cohort. We did analyze data as part of routine practice, so you can imagine there could be some inaccurate or missing data, but the UK registry team does have an excellent program of data cleaning and regular validation visits to CF centres to ensure completeness and accuracy of data. And there is some variability on the duration of follow-up and the observation period across patients, and this was because we wanted to include as many patients as possible according to the eligibility criterion, regardless of length of follow-up. And as already alluded to in the introduction, the early part of this analysis does coincide with the COVID-19 pandemic, but pleasingly what we're now seeing is that we have at least 2 years outside of the pandemic, and what we see is that these results continue to be consistent. So, in summary, among people with CF in the UK aged at least 6 years old, ETI treatment was associated with reductions in healthcare resource use, and this was looking at pulmonary exacerbations, as well as inhaled oral antibiotics and other CF-related medications. These findings complement the positive benefit risk established in phase 3 trials and other real-world studies, and what we do is we add in some data here focusing on the improvement in the burden of illness. As some of you will have noticed, a number of people do continue to have pulmonary exacerbations despite being on ETI, indicating that further improvement in CTFR function might help in reducing disease burden and improving outcomes. So what that leads me to do is to make some acknowledgements. So I'd like to thank the excellent collaboration that we have with the UK CF Registry and UK CF clinicians on this study. But most importantly, I think we need to thank the people with CF and their families for consenting for the data to be held in the registry, as well as the teams at the CF centres in clinic that put the patient data in the registry. So thank you very much for listening. Really happy to answer any questions you may have.
So one of the questions that I had is, you're looking at rates of pulmonary exacerbations based on IV antibiotics.
Yeah.
Is there a way that you can, and we kind of talked about this a little earlier, but is there a way that you can get at antibiotics that are prescribed, like, either over the phone or oral antibiotics to kind of get a sense of, exacerbations in that light?
So yeah, we typically do look at just IV for pulmonary exacerbations, which is one of the reasons why we wanted to look here at inhaled and oral also. So I know one we look at rates, the other one we're looking at number and proportions, so it's a little bit differently. So it is pleasingly to see that we do see decreases across the board in all antibiotic usage.
Awesome.
And as part of the UK registry, is that capturing oral antibiotics that are prescribed during a discrete clinic visit or prescribed at all?
It is, I'm afraid I don't quite know. Sorry.
Awesome. And we will take questions. You're welcome to come up to the mics, and you're also welcome to submit it through the app if we can get that to work. But thank you so much.
Can I ask one additional question? Sure. As you're looking at the decrease in healthcare utilization rates, are you also looking at the financial impact of that in comparison to the cost of the medications?
We can do that, and we do that in respect to kind of economic modeling. So that's some of the inputs that we do put in there, kind of the cost offsets, and that's something that we can do, yeah.
Great. Okay, no questions have come through on the app either, but I think we will have some additional time at the end if people think of questions during the rest of the session.
Yep. And as a shout out, we all get to go stand at our posters from 12:15 to 1:15 after this. So you can find us after this or by our posters. Awesome. Thank you, Dr. Becky.
Thank you.
All right. So it's my honor to introduce our next speaker, one of my other mentors from residency, Dr. Clement Wren. He's a professor of pediatric pulmonology at Children's Hospital of Philadelphia. He'll be talking to us about risk factors for pulmonary exacerbations in people with CF stopping chronic daily therapies.
Great. Thank you very much, Dr. Buzek and Dr. Hoppe, for inviting me to speak, and for all of you for coming. I won't repeat the title because we just heard about it, but I do want to acknowledge all my co-authors, in particular Kevin Soder, our biostatistician, and my co-principal investigator, Cindy Brown. These are my disclosures. Our previous speaker set up this talk perfectly because he pointed out these two key points, that ETI has significantly reduced but not eliminated pulmonary exacerbations in people with CF. At the same time, as we just saw, and we know from many other studies, many people with CF taking ETI have stopped other chronic daily therapies. So identifying risk factors for PEX in this group of people with CF would be helpful in shared decision-making around CDT discontinuation. And that was the motivation for our doing this analysis with the objective of using data from the HERO2 study to identify risk factors for PEX in people with CF taking ETI who have stopped chronic daily therapies. So as I mentioned, we used the HERO2 study. We recently published the methods last year in chest pulmonary, but in brief, HERO2 stands for the Home Reported Outcomes 2 study. This was a prospective study of chronic daily therapy use and symptoms in people with CF taking ETI. We enrolled 860 people with CF, and each individual participant tracked their medication use and symptoms for 12 months. And tracking was done using a smartphone app created by a company called Folia. And as I mentioned, both symptoms and medication use were tracked. So for this study, one of the key, unique aspects of the HERO2 study is that participants gave permission to link their HERO2 data to their CFF patient registry data so that we had both their symptoms, medication use, and clinical outcomes. And then for this analysis, our primary outcome was IV antibiotic-treated pulmonary exacerbations because, as people may know, in the US CFF-PR, oral antibiotic use is not captured. And we used descriptive statistics to compare demographic and clinical features, and then multivariable logistic regression to calculate odds ratios for selected risk factors. So this slide shows kind of the breakdown of patients. I mentioned we enrolled 860, but we lost some patients because we couldn't make a link or we had incomplete data. So we ultimately had 754 patients available for analysis. Of those 754, 313, or 41.5, had reported already stopping a chronic daily therapy at enrollment. And of course, then the other half reported no changes. So if we look at those people who had stopped CDTs, the vast majority, 90.1%, did not have a pulmonary exacerbation at all during the 12 months they were in the study, but about 10% did. Looking at the people who continued CDTs, actually, the vast majority did not have PEX, although, again, it was a little bit lower, and about 16% of people who had continued had PEX. And that's because we previously showed this, that the people who continued chronic daily therapies tended to be sicker, so it's not totally surprising. So if you add up that total number, it's 101 participants, or 13.4% of the total study cohort, which is remarkably similar to the IV antibiotic-treated exacerbation rate in the registry overall. So this slide shows the relationship between baseline FEV1 and pulmonary exacerbation. So over here on the left-hand side is the group that stopped chronic daily therapy, and in blue are the people who had pulmonary exacerbation versus the green bar, which is people who did not. And as you can see, baseline FEV1 was significantly lower in the people who had PEX, with 79.7% predicted compared to 92.9% predicted. And we actually saw the same pattern in the people who continued. Again, significantly lower FEV1, 78.0% predicted compared to 90.7% predicted in the people who remained exacerbation-free. So next we looked at the relationship between BMI at enrollment, and here again we saw a significantly lower BMI in the group that stopped CDT and had a PEX, shown here in the blue bar, versus those who did not. Now, there was actually a lower BMI in the group that continued, but this difference was not statistically significant. We're going to kind of see some of that a lot because the actual numbers, when you get down to it, are pretty small, so the confidence intervals end up being rather wide for some of these measurements. When we looked at age, we saw an interesting pattern where people who had a PEX in the stopped CDT group were significantly younger, and whereas in the group that continued, they were actually slightly older, although again, this difference was not statistically significant. And then finally, to summarize some of the other risk factors we looked at, again, over here on the left is the stopped CDT group, and on the right is the continued. You know, if we looked at sex, there was no difference, but things like a history of Pseudomonas, history of MRSA, CFRD, and prior exacerbation all were significantly higher in the group that had PEX. And again, we really kind of saw a similar pattern, although again, some of the differences were not statistically significant simply because we had small n's, although for some reason there was a slight male predominance in this continued group. But I think, as we'll see from when we look at the odds ratios, I think what's really striking is if you look at a history of prior pulmonary exacerbation, right? So this is basically saying, like, the people who had stopped a CDT of the people who ended up having a pulmonary exacerbation, almost half of them had had a PEX in the year before. Whereas really, if the people who were exacerbation-free, very few of them had a previous history. And we saw the same pattern, whether or not they had stopped or continued a CDT. So this slide shows the odds ratios for demographic risk factors for PEX. The red line represents an odds ratio of 1, in other words, neither increased or decreased odds for PEX. And in the green squares are the group that stopped CDT, and these light blue or lavender circles are the continued CDT group. I'll point out also that this odds ratio scale, it's a log scale, because otherwise that's the only way you could fit the confidence intervals in. And although a lot of the point estimates fall above and below 1, you can see from that the confidence intervals also crossed 1, meaning that these were not significant. The only statistically significant demographic risk factor was age over 35, so older people with CF who had stopped CDT had a significantly lower odds of pulmonary exacerbation. Turning our attention to clinical risk factors, once again, the same format. The red line is OR of 1, and we have a log scale. We can see that an FEV1 percent predicted of less than 40 was associated with a significantly increased odds in the continued CDT group. Again, you can see that the point estimate for the stop CDT group was also high. It's just that the confidence intervals were wider. Remember, we really only had about 10 people who had a pulmonary exacerbation. And in fact, there were really, I think there was actually one person with an FEV1 percent predicted less than 40 who had stopped their CDT who actually had a PEX. So that's why you end up with such wide confidence intervals. And conversely, we saw two things that were associated with a lower odds ratio. Well, mainly they're kind of the same thing. A higher BMI, whether it was 25 to 30 or 30 and above, was associated with, again, quite a significantly lower odds ratio. But really, if you look at the biggest single risk factor that with the highest odds ratio for PEX, it was a history of PEX in the year before. Whether that was somebody who had stopped their CDT or continued their CDT, you can see that I'm just showing it for stop CDT. The odds ratio is 19.4. It was very similar in the continued CDT group. So in conclusion, first of all, risk factors for PEX, first of all, were similar between people who stopped CDTs and continued CDTs. And I gotta say, when we did this initially, when we planned this analysis, I kind of was thinking, oh, there's going to be something special or different that we can identify in people who stopped CDTs as a risk factor, but we really didn't see that. And I think what's also interesting is that, again, whether or not you continued or stopped your chronic daily therapy, ETI, it reduces the total risk for pulmonary exacerbation, but again, if you look in the pre-ETI literature, all the risk factors that I showed you, they're the same risk factors. In fact, in particular, a previous history of pulmonary exacerbation. Even before ETI, that was by far the strongest single risk factor for a future PEX. And so as I mentioned, that's kind of like the key identifying positive risk factor or risk factor, and clinical features associated with a decreased risk of PEX are older age and higher BMI. And these results can be used for shared decision-making around chronic daily therapy use in people with CF taking ETI. So then in closing, I'd also like to acknowledge our funding through the CF Foundation, all the individuals that contribute data to the CFFPR, our project team members, Laura Eddy, the parent of a person with CF, Gunnar Esiason and Jackie Schober, two people who have CF who helped plan this study, and also a couple of other people who were at the foundation at the time that we developed this study, Eliza Fink and Bruce Marshall, for their early support of our work. Thank you again for inviting me to speak, and I'm happy to take some questions.
Hi, Marianne Mullerbeck from UNC. Apologies if I missed this, but which chronic therapies did you track? Was it only pulmonary ones or only inhaled antibiotics? Yes, no, all
Yeah,
of
no,
these.
great question. I probably, I actually didn't realize I had more time than I realized. I probably could have put that in. So it was so again, that's why I said we used therapies, not medication, because it was any medication, but it was also airway clearance. If you looked at, we recently published the baseline characteristics in pediatric pulmonology earlier this year. But if you look at like kind of the distribution, it's kind of all over. I mean, it was like 20%, it was airway clearance, and like 19% it was Dornase alpha. And there were many patients who had stopped 2 or 3, or not that many who stopped 4, but there were. So it was any of those. And for this analysis, we did, the numbers would be too small, I think, to kind of try to break it down.
Thank you.
Hi.
Okay.
Thank you for your talk. I'm Ryan Kelly. I'm not with any university. I'm a dad of Joey, my 9-year-old son with CF. So I've been tracking this work very closely because for obvious reasons, it has implications on our day-to-day and all the things that we do or don't need to do. And I think you answered one of my questions just a minute ago. I was curious if you had done any sub-analysis on that group of patients that had stopped all daily breathing treatments. But it sounds like that N was too small.
Yeah, we haven't done that. The answer is no. I think what we could do is look to see exactly if our N's, if we have a large enough N to kind of be able to do any subgroup analysis by type of treatment discontinuation or number of treatments, we'll try to do that, but we haven't yet.
Cool. Thank you. And then one more question. And you might have said this, and I apologize if I missed it, but when you talk about one of the risk factors being a previous pulmonary exacerbation event, did you define what that?
Yes.
Okay.
Yeah. So again, what I mean that's again, we're using registry data, so that's an IV antibiotic pulmonary exacerbation.
Okay. Thank you very much for your work.
Thank you.
We have a question. Oops. A question from online. What are your thoughts about seeing fewer exacerbations in older patients? Is that related to duration of ETI use, perhaps?
Yeah, I think it's always hard to assign causality in an observational study. It may be, again, people who are older, if they've got the same FEV1 as somebody, it may be that they, again, just they're healthier. One of the things we also didn't look at was how long people have been on medication and things. So I think it's hard to really, from an observational study, really identify sort of what, anything beyond just the association. Did you have questions, Leslie? I mean, Lindsay? No. Okay. Great.
Another question that I had, kind of along the lines, it looked like, those that are 35 and older have a decreased risk of pulmonary exacerbation. And you kind of alluded to a little bit, it's like, maybe they're healthier. But one of the things that I thought was interesting is that, all of these other factors of, whether you're on chronic daily therapies or not, they're all pretty similar. So do you feel like that, folks that have lived with CF for longer, that have been more exposed to having those exacerbations, do you feel they're more likely to be like, oh, I remember what this was like, I'm going to put these back on? And then if that's the case, what, I guess, thoughts do you have about how we talk to younger kids that are now being on ETI that may not have had that experience?
I think that's an excellent thought. Again, we don't capture anything that happens before the exacerbation, right? So it's very possible that people who have been living with cystic fibrosis longer are more aware, more self-care, more self-aware, and might ask for oral antibiotics sooner and do things like that would prevent pulmonary exacerbation. And I think that it conversely, yes, I think using these results for, shared decision making at any age will be valuable. I mean, I think even this prior history of pulmonary exacerbation, I mean, because we know, some of it may be more disease severity, but it can also be, I'm sure we all, take care of people who don't take their medications and end up in the hospital because they don't take their medications, including ETI. So it's not just disease severity, but I guess what I feel like what this analysis, well, I feel like this analysis shows a couple of things. That really PEX risk factors haven't changed, and that, people who have been in the hospital the year before, those are people that, you probably do want to be seeing more closely, or at least staying in contact more closely, and trying to, mitigate or prevent hospitalization.
Thank you.
All right, thank you.
All right, our next speaker is Dr. Lindsay Caverly. She's an associate professor of pediatric pulmonology at the University of Michigan. She'll be talking to us about the epidemiology of Pseudomonas aeruginosa infection before and after the 2013 infection prevention and control guidelines.
Thanks for the introduction, and thanks for the opportunity to be here today. Looking forward to switching gears a little bit for the session and speaking about Pseudomonas aeruginosa. And I was hoping to start this off with a little bit of a historical perspective on why we're talking about the infection prevention and control guidelines. And we've known since the 1990s that there's the occurrence of person-to-person transmission of CF pathogens. This was one of the earlier reports of transmission of Pseudomonas cepacia from John LaPuma's group. And data like this led to the initiation of the 2003 CF Foundation Infection Prevention and Control Guidelines. And these guidelines made recommendations for things like the physical separation of people with CF and hand hygiene. Over the following decade, we got more data about transmission, including members of the Burkholderia cepacia complex, Pseudomonas aeruginosa transmitted between people with CF, and really this extended to nearly all of the CF pathogens. So this is a table from a 2014 paper that listed the evidence available for the frequency of shared strains of different CF pathogens. And you can see that this includes Pseudomonas aeruginosa, Burkholderia, but also methicillin susceptible and resistant Staph aureus, Stenotrophomonas, Achromobacter, and Mycobacterium abscessus. And so these studies led to the updates of the infection prevention and control guidelines. So the 2013 update from the CF Foundation and from the authors listed here included updates for CF care centers, such as contact precautions for all people with CF, mask use by people with CF in the common areas of the healthcare setting, keeping a minimum of a 6-foot distance between people with CF, and then additional recommendations for cleaning and disinfecting healthcare-associated surfaces, including pulmonary function testing equipment. And the results of the 2013 IP and study guidelines, one, they were associated with reduced rates of CF pathogen infection. This was a CFF patient registry-based study led by Marianne Muehlbach and team that looked at center-level mean incidence rates of MRSA and Pseudomonas aeruginosa infection of the 3 years before the 2013 IP&C guidelines compared to the 3 years following implementation of the guidelines. And you can see here that there was a temporal association between the IP&C guidelines and a decrease in incident rates of MRSA in the pediatric population, and then Pseudomonas aeruginosa in both the pediatric and adult populations. This, of course, is a temporal association, and there's a lot of factors that play into changes in CF pathogen prevalence, including changes in other treatments and general improvements in CF care. And so there's remaining knowledge gaps in terms of how the 2013 IP&C guidelines may have impacted rates of person-to-person transmission and healthcare-associated infection in people with CF. And so this led to an overarching study that was led by Marianne Muehlbach, Lisa Saman, and John LaPuma to help address this and other knowledge gaps in regard to the IP&C guidelines. And so what I'll be speaking about today is a subset of this larger study. And the data that I'll be presenting was led by Thomas White, who was a master's in public health graduate student in my lab this past year. He's since moved on to another position in pursuing medical school applications, so wasn't able to be here today to present. And so what we did with this study, this project looked at Pseudomonas aeruginosa isolates from people with CF based on the year of incident infection. And this was divided into cohorts based on relationship to the 2013 IP&C guidelines. So there was a cohort of people who had incident infection pre-IP&C, which was 2007 to 2010. A cohort of people who had incident infection post-IP&C, which was 2015 to 2018. Isolate collection started just following this and really was coincident with the onset of the COVID-19 pandemic and then also the introduction in ETI. And so we were able to have a third cohort of people who had incident infection post-ETI and during the COVID-19 pandemic. And so clinical isolates were collected through clinical care when they were identified in the clinical microlab as being from someone with an incident infection that fell into one of these time periods. The isolate was identified and then was sent to us at the University of Michigan. And this relied on the assumption that the isolate that was collected at the study time period reflected the same strain that the person had at the time of incident infection. And this is supported by a large body of literature that shows that the majority of people with CF are infected with the same strain over time. So with the isolates, we performed whole genome sequencing. We relied on multi-locus sequence typing, or MLST, for the strain genotyping. And the primary objective with these data were to identify rates of Pseudomonas aeruginosa strain sharing within a CF center. We define strain sharing as the same strain of Pseudomonas is found in one or more people with CF within that center. The secondary objective with this was to assess changes in the strains over time. And for this, we paid particular attention to the previously described epidemic or clonal strains, which we defined as a shared strain that has been known to infect the CF population across centers and or regionally. We relied on this excellent review article by Valerie Waters and colleagues to pick some of these epidemic and clonal strains of interest, and this is a selection of the strains that we're interested in, including clone C, Liverpool epidemic strain, and I will point out that this is a mixed bag of epidemic or clonal strains. Things like clone C are known to be widespread environmental clones, not thought to be person-to-person transmitted, as opposed to some of the epidemic strains that do have stronger evidence for person-to-person transmission. So these are things that had to factor into our data analyses. So to start with the results, I'll talk about the samples that were collected with this. In total, we looked at 200 Pseudomonas aeruginosa isolates. These came from 183 people with CF, and they were collected across 9 CF centers, and these included both pediatric and adult centers. There was a good amount of variation in terms of number of isolates per center and also the distribution of the timing of isolates across the different time periods of interest. So just to show here, you can see a couple centers had larger numbers than others, and it wasn't always equal distribution across the time periods. So the first result I'll talk about are the results of the intra-center shared strains. And we found that in the pre-2013 IP&C time period, 16% of people with CF had a Pseudomonas strain that was shared with at least one other person within that center. This represented 80 of the 50 people in total in this cohort, and this included people across 4 different centers. In the immediately post-IP&C time period, this was 12% total of intra-center shared strains. This was 6 of 50 people with CF across 2 centers. And then in the final time period, the post-ETI and COVID-19 period, it was a total of 23% of intra-center shared strains, 19 of 83 people with CF across 4 centers. We also looked to see which of the strains were being shared and how did that overlap with our list of epidemic and clonal Pseudomonas strains. And we found that in the pre-IP&C time period, of the shared strains, 1 was clone C from 1 center, and none in the middle time period, but in the final time period, the shared strains included clone C from one center, and then one of the STs from one of the Spain epidemics in one center. So in addition to looking at shared strains, we also looked at just sort of distribution of the STs that were infecting people with CF across the time periods. Again, with a particular attention to the epidemic and clonal strain list that I talked about before. And this is not just the shared strains, this is across the entire set of isolates that we received from these time periods. 16.7% in the first time period were of the epidemic strains, including the ones listed here. 16.1% in the middle time period, including clone C, Spain, and ST298. And then finally, 14.4% in the final time period. We also looked to see which strains were found across different CF centers, and this helps put things into context a little bit. If, for instance, there's one ST that seems to be shared within one center, if that's the only time that you see that ST, you might interpret that differently than if you see that ST also widely distributed across multiple centers. And you can see that clone C was the strain that was found most often across centers, found in 6 centers and at least 12 people with CF. But there's a number of STs that were found in multiple centers and multiple people with CF across those. So there's some limitations with this. One, the small sample sizes did limit some of the intracenter assessments. And similarly, within centers, we weren't always able to do the comparison across the time periods because of some imbalance in the collection. We didn't have epidemiologic data to identify the cause of the strain sharing, so this is, again, sort of a temporal association. And I'd like to remind everyone that a shared strain within a CF center could have multiple causes. It could be from person-to-person transmission of the infection. There could be acquisition from a common healthcare source. If, for instance, there's a sink in a hospital room that multiple people with CF are seen in over time, and they could each independently get that from the same healthcare source. Or there can be infection with a widespread environmental clone, like clone C that I mentioned, which is thought to be one of the most widespread and common Pseudomonas aeruginosa clones and likely reflects independent acquisition from the environment as opposed to person-to-person transmission or acquisition from a healthcare source. We chose to use MLST for genotyping, acknowledging that this could be less discriminatory than using the whole genome sequencing data. We did this intentionally to be able to put those data into PubMLST, assign a sequence type for those, and then be able to put that in context of the prior data that's known about Pseudomonas aeruginosa sequence types and the epidemiology of those over time. We did do a double check on this to make sure we weren't either over or under calling the rates of shared strains within the data set by using the core genome data, and we were reassured that the results were very concordant between those two. We also weren't able to account for center-to-center variation in IP&C practices. I think the changes that occurred with the COVID-19 pandemic are one example of that and how that potentially could have impacted the results. But we also know that there are some barriers to implementing the IP&C guidelines, both from the healthcare provider standpoint and also from the standpoint of people with CF who, it is difficult to wear a mask around the healthcare setting. And there, fortunately, are other groups who are working on these barriers and trying to help evaluate how we can improve our IP&C measures, but we weren't able to sort of layer on the IP&C guideline adherence to the strain sharing data that we have here. So in summary, we identified that shared strains of Pseudomonas aeruginosa within CF care centers continued to occur with current IP&C measures. This does include some previously described epidemic and clonal strains. This does not provide conclusive evidence of person-to-person transmission or healthcare-associated infection, and more likely based on the strains that were identified, infection with common environmental strains. And monitoring of CF infection epidemiology continues to be important, as Drake nicely set up at the beginning of the talk. We know that chronic infection persists in many people with CF, and new infections continue to occur as well. And so this will continue to be an important area and to keep refining the IP&C measures to improve outcomes. And so I want to thank our team at the University of Michigan. Again, Thomas White led most of this work. Jacob Evans was our bioinformatician who did most of the genomic data analyses. And then John LaPuma and Marianne Muehlbach and Lisa Saman who led the overarching project. And then Linda Calican and Ted Spilker, our lab members who were important to these efforts too. This was done through the CF centers and the TDCs, and so we appreciate their help in identifying the isolates and shipping them to us, and appreciate the CFF funding. Thanks, and happy to take questions.
We do have one question in the chat. Did you take siblings into account when assessing for shared strains?
Yeah, thank you. Yes, we did to the degree that we could. We didn't have sibling data available for all of the centers, but we had it for about half of the centers, and the sibling data overall did not account for the shared strains. We did not have very many sibling pairs within the data set.
Thanks, Lindsay, for an important study and a great talk. So if I understand it right, you sequenced the incident Pseudomonas isolates, but you didn't take isolates from chronic patients at those centers who could potentially be the source of transmission, because we've done a similar study at St. Kitts, and we did find a chronic to an incident, but you didn't sequence those chronic isolates, right?
The collection were from incident isolates. We did look over broader time periods. So if you took the two post-IP&C time periods, what I presented was just looking at those periods individually, but we also looked at that as a block, and so you'd get sort of a broader representation of what the chronic infections were over that time period, and the numbers were similar, but that's a great point, that if we had collected all chronic infections, we might have had a different picture of it as well.
We have another question from the app. Do you think this indicates any changes are needed in the IPC guidelines?
I don't know if we can. I don't think we can conclude anything about the IP&C guidelines. I think this is going to be a bigger project and ongoing work to further refine the IP&C guidelines. And yeah, I don't think we have data from this to support definitive recommendations.
Oh, and you may have said this at the beginning. Are these all, where are these isolated from? The strains, are they from like a mix of like sputum and OP and lavage?
We targeted sputum samples.
Oh, okay.
For these, yeah. Can't guarantee you it was 100% sputum samples, but that was what was primarily targeted. Yeah.
And can the similar analysis be done from other sources too?
Yeah, and I'm not aware of data that would say that sampling from other sources would give you different results in terms of which strain of Pseudomonas is infecting. So if they were from OP swabs, I would assume that you would have the same strain as you would isolate from sputum samples too.
Great, thank you.
Thank you.
Awesome. Well, big thank you to the three previous speakers. So you know me and you're probably sick of me at this point, but I'm really excited to be talking about the research that I did during my fellowship here at the University of Washington and Seattle Children's Hospital with Luke Hoffman and his lab, where we use shotgun metagenomic sequencing to evaluate clinical utility of OP swabs in kids with CF on UTI. These are my disclosures. So CF lung disease is caused by underlying chronic infection and inflammation. We've heard a lot about how modulators, specifically ETI, have been helpful in terms of in those people with CF that are 6 and older, they have improved lung function, decreased exacerbations, and reduced abundance of traditional CF pathogens in sputum. But the pathogens still persist, even up to like 4 to 5 years, as seen in the adult PROMISE studies. And also there's decreased sputum production as well. Dr. Jessica Pittman and the Promise Peds folks published their results on post-approval monitoring of ETI in kids 6 to 11. And they saw that both lung clearance index and FEV1 Z-scores did improve on ETI. Interestingly, so lung clearance index is, for those that may not be familiar, is multiple breath washout. You have a tracer gas, and you count how many times, how many lung turnovers it takes to get to about 2.5% remaining gas. And they found that lung clearance index 2.5 was a little bit more sensitive in this population. So 43% had what was deemed a clinically significant improvement, so a 10% improvement from prior, as opposed to just a quarter in FEV1. And so the data that I'll show later on all kind of focuses on LCI, but those associations are very similar to what we see in FEV1. In that same paper, they took a look to see what pathogens are present in people 6 to 11-year-olds with CF on ETI, and this is from sputum culture. And so here on the vertical axis, we have the samples positive for the indicated species, with the indicated species being represented by the color indicated on the legend on the right. And then on the horizontal axis, we have time on ETI, with 0 being before ETI, and then points at 1 month, 3 months, and 1 year. And then at the top, we have the number of sputum samples that contributed to this data. And this is all from Dr. Pittman's paper listed below. And what we see is that in this age group, it's very similar to those that are 12 and above, where traditional CF pathogens persist, but they don't, or that they decrease, but they persist. And so if you take a look at Staph aureus, about 80% of 6 to 11-year-olds had Staph aureus isolated from a respiratory sample, but that still remained at about 60% down the line. Pseudomonas in green did pop up a little bit at 1 month on ETI, but then went away. But one of the things that's relevant to what I'll be talking about in a second is that the amount of sputum produced in this group also decreases quite a bit. So before ETI, 43% of individuals were able to produce sputum. However, in the 12 months on ETI, only 8% of those individuals were able to produce sputum, which raises a question: what clinical respiratory samples should be used to monitor infection if sputum production is limited? So right now, oropharyngeal swabs or OP swabs are recommended for infection monitoring in kids with CF not producing sputum. This is primarily looking to see if Pseudomonas aeruginosa is there, because there's high specificity and negative predictive value for predicting BAL culture. And there's comparable outcomes if you use OP swabs to guide eradication therapy as bronchoscopy guided monitoring and eradication. Most of the OP swabs to date have assessed correspondence with cultures of samples from other respiratory compartments. So basically asking, is what you find in a swab what you find in sputum, or what you find in BAL, or what you find in a nasopharyngeal swab? And not very many have looked to see how just the contents of an OP swab alone associate with clinical outcomes. There was a paper in 1993 that did assess this, where Pseudomonas aeruginosa and Staph aureus that was isolated within the first 2 years of life on your initial swab culture was associated with a 10-year, or a decreased survival at 10 years. But 1993 was a long time ago. A few things have happened since then, and our care has come a long ways. And so these all bring the questions, ETI didn't exist during these studies. So are these findings still applicable to what we're getting now, especially as kids are starting on modulators earlier and earlier? And what should we do with this information? So if we think about OP swabs, it's helpful for me to think about what actually is in it. So you're going to have epithelial cells from the lining. You're going to have airway mucus, inflammatory cells, and then of course our favorite, the microbes. And it's important to know that the oropharynx is basically a grand central station of microbes from a lot of different places. So this is going to pick up bacteria that are coming from the upper respiratory tract, sinuses. The oral cavity has individual microbiomes based on the surface that's there. It will pick up stuff from the lower respiratory tract, and can even pick up stuff from the gastrointestinal tract. And so what we're curious about is, regardless of the origin of what bacteria we find on the swab, how does the OP swab microbial content and characteristics relate to clinical outcomes? And can this be used as like a biomarker? Now, there's a lot of different ways that we can figure out what's in a swab. So currently, there's selective CF culture media, amplicon sequencing, so this is like 16S, and then shotgun metagenomic sequencing, which we ultimately did. And there's pros and cons to everything. So selective CF culture media has been developed over time to be optimally, have the optimal conditions to grow traditional CF bacteria. It's used clinically, and this is, what a lot of folks use and what a lot of the studies have been based on. One of the disadvantages is that it has limited detection of unculturable bacteria or bacteria that won't grow in those very specific media conditions. For amplicon sequencing, this gives you a little bit better chance to detect unculturable bacteria, and it selectively sequences bacterial DNA in complex samples. However, the resolution isn't high enough to give you identification of bacterial species or strains. And so, you could have coag-negative staph and Staph aureus, and those mean two very different things, but all show up under, the genera of Staphylococcus. So shotgun metagenomic sequencing can give you the chance to detect unculturable bacteria, can give you species and strain level identification, though you can run into issues with low biomass samples that have a large amount of human DNA, kind of like OP swabs, in narrowing down the microbial content that you're sequencing. So the big knowledge gap that we're looking to evaluate is, is OP swab microbial data in kids with CF on ETI associated with lung function? And then how does shotgun metagenomic identification compare with selective CF culture when you identify bacteria from swabs? So in our study, this is kind of the very early analyses, and more will be coming later, but we compared OP swab microbial characteristics with lung function, and then bacterial identification sensitivity between culture and metagenomics. As I mentioned earlier, we utilized the PROMISE PEDS study that was 124 kids with CF, 6 to 11 years old from 20 centers, so a very robust study. And we got lots of swabs. So we had dual tip swabs that were collected, so kind of one swab that one was sent and done like standard clinical culture, the other was metagenomics, and then at that same visit we have pulmonary function. And so the data included in this analysis is for those that have both a pulmonary function test, and that could be spirometry or multiple breath washout, and qualitative culture and metagenomics done. And this data, or these points were collected before ETI and then at 1 month and 3 months in ETI. The PROMISE PED study goes out to a couple years, and so we can look at that kind of down the road, but this is our initial look at things. So just a very brief overview of what we do and how we get, from swab to data. We get our swab, we extract the DNA, we send it off for shotgun sequencing. So shotgun sequencing is going to sequence every single piece of DNA that's in there, regardless if it's microbial, human, or other. And of clinical importance, it's going to sequence DNA from microbes that are alive and culturable and can grow, and also DNA from microbes that have been killed by antibiotics. We put it through bioinformatic pipelines, and we can get things like relative abundance, diversity, and gene presence. And I'm not going to talk about this today, but we spent work trying to figure out, can we increase the yield of our microbial reads, and can we get at the bacteria that is culturable? And we get pretty close if we use an endonuclease to digest extracellular DNA. And I'm happy to talk more about that at a poster or later. So what did we find? So looking at oropharyngeal swab cultures in this cohort in 6 to 11-year-olds before and after ETI, again, we have the number of samples, or the percentage of samples with a given pathogen, yellow being Staph aureus, green Pseudomonas, pink, that's not pink, purple being Stenotrophomonas on the vertical axis, with time being on the horizontal. And this looks a lot like what we saw in the sputum, where Staph aureus is most abundant, which is typical for this age group, and it decreases a little bit over time. Pseudomonas is there. It pops up a little bit at 1 month, which we also saw in sputum, but then goes away, as does Stenotrophomonas. So if we look with shotgun metagenomic sequencing, we see a very similar pattern. And so again, this is just the percentage of samples that identified the presence of one of these pathogens. And we see that, with pre-ETI in Staph aureus, it stays about the same at 1 month and then goes down over time. So I think what's curious is if you look at, what do we detect with culture versus what do we detect with metagenomics? And kind of on first blush, our culture is a lot more sensitive at picking stuff up than metagenomics is. As you can see, for Staph aureus before, there's about almost 80% was identified on culture, whereas only about 45% was identified on metagenomics. And so we're kind of curious, it's like, all right, what's causing this difference? So when we look at oral pharyngeal cultures, this is showing the percentage of samples. So if we had a sample that had Staph aureus grown on it, or not grown on it, it was done for culture, it is listed there, with pre-ETI, 1 month, and 3 months on ETI on the horizontal. And we divide this up based on semi-quantitative abundance. So the teal means that 0+, there's no bacteria in there. Orange is 1+, purple 2+, pink 3+, with the higher numbers representing more bacteria. And so the two things that stuck out to me were if you focus at the bottom and look at purple and pink, so 2+ and 3+, that abundance goes down and is less prevalent over time on ETI. The second thing that we took away from this is if you look at orange, so the 1+, so it's present, but it's not there in much abundance, that actually goes up. So, could selective culture be so good at culturing things that, we're getting stuff that's not being detected or it's below the limit of detection with metagenomics. If we look at relative abundance of Staph aureus in using metagenomics, we see that about 13-ish% of samples had Staph aureus detected, and that dropped down to 5% and then about like 2%. So there's a pretty big difference there. And so one of the questions we asked as we're kind of going through this is, does the metagenomic abundance correspond with semi-quantitative culture abundance? And the short answer is yes, it does. And so on our horizontal axis, we've got the semi-quantitative abundance with the corresponding relative abundance by metagenomics on the vertical axis. And we see that, OP cultures that have 3+ bacteria present have higher amounts of staph detected with sequencing. And what's interesting is if you go to the 1+, there's a good number of dots that are kind of all smushed underneath that mean line that are not detected on metagenomics. There are a few, but as we get higher and higher, it kind of reaches that level of detection with metagenomics. So the important thing is is Staph aureus abundance clinically relevant? And so it's obviously a very loaded question, and we're going to get but we'll look and see what we see. But if we look at lung clearance index, which again was improved in kids 6 to 11 on ETI, and this graph is showing all, each point is where a visit where lung clearance was performed and a swab was cultured and was also on metagenomics. So this is irrespective of being on or off ETI therapy, and that's something that we're going to look at and split this out. But what we see is if Staph aureus is present, there's a statistical significantly different, but you look at that and it's like, those are basically the same. The hashed line there indicates anything above that is going to be an abnormal lung clearance index, so it takes more lung cycles to clear out the tracer gas. So like I said, these are likely not clinically relevant differences. And but what happens if we look with a greater resolution? So again, sticking with the cultures, if we look semi-quantitatively, again, the more Staph aureus that is present on the semi-quantitative culture, there is higher lung clearance index. Again, these means are pretty close, and what's the difference of one lung clearance index? We're going to be looking at kind of subdividing this into those that had a clinically relevant change, so that 10%, and seeing kind of how this shakes out. But I thought this was pretty interesting. And again, we see a similar pattern if we use metagenomics, where the more Staph aureus is identified on a swab from metagenomics, there's significantly worse lung clearance index. So my last two slides are, what is the clinical relevance of metagenomics? Again, another loaded question. So shotgun metagenomic sequencing provides an opportunity to get insight on associations between complex microbial communities like we see in swabs when you've got stuff coming from everywhere, and looking at how those are related to clinical outcomes. So what we have is modeling of kind of predicting lung clearance index based on different parameters. And so on the far left, we have Staph aureus by semi-quantitative culture. And there's a weak relationship, your R is about 0.14. If we do metagenomic relative abundance, that R goes up a little bit. If you add metagenomics and add other measures of, other crude measures of microbial diversity, like Shannon diversity, that association gets higher. And then I think one of the interesting things is that, by using metagenomics, you can get at some of this hypothesis generating stuff. So what we found is if you use Shannon diversity, a very specific strain of Staph aureus and a very specific strain of Prevotella, you have an even stronger relationship between the presence of those and what your lung clearance index is. Now, is this going to be clinically relevant, or do we need to, screen everybody for Prevotella 58566? Who knows? But it gives us a place to look as we kind of move forward. So, could this serve as a biomarker? And again, big caveats, these are early analyses, and we can use these for generating hypotheses, and clinical utility would definitely need to be tested. But we're excited that we have the opportunity to collaborate with the CFF and utilize these resources to kind of start to look at some of these questions. So in summary, selective CF culture methods are more sensitive at detecting traditional CF pathogens than metagenomics. But if you look at metagenomics and quantitative culture analyses, they have similar prevalence patterns and clinical relationships when you look at LCI. The Staph aureus prevalence does decrease on ETI, and your lung clearance index is higher at visits, where Staph aureus abundance is higher, identified for both ways. Other things that I didn't have time to talk about today is we're looking at other factors. So we have seen that, measures of diversity like Shannon diversity are associated with lung function, specifically lung clearance index. And this association holds true even if you exclude traditional CF pathogens. So again, it's kind of reading the tea leaves and trying to figure out what's relevant. But we also see that the composition, the microbial community, or the microbial composition of the swab does change in individuals that expectorate sputum. And so, could this be indicative that, people that are expectorating sputum have, worse lung disease? Or is it that, you cough and you expectorate sputum and now have a greater contribution from the lower airways? So with that, like I said, we're going to be looking at, acute and chronic ETI effects, and then, are there differences in ETI responders and non-responders? And our plan is to kind of triangulate things by using quantitative PCR with these same swabs to see what is sort of our detection threshold with each of those. This is all going to serve as a way to evaluate this in younger kids, because we have about 2,000 swabs from kids in the freezers, up by 5 a little bit, that are being extracted. So huge thank you to the Hoffman Lab. Chris Pope and Angshita Dutta have been absolutely instrumental in helping me to extract hundreds and hundreds of swabs. Hilary Hayden and Adrian Verster have been awesome with helping with the informatic analysis, and I'm very grateful for Luke Hoffman for taking me in his lab and letting me kind of explore. And so with that, I will wrap up and take any questions.
Hi, I'm Laura Brenner from Massachusetts General Hospital. Great talk. Thank you so much. I had a couple questions about your metagenomic sequencing, mostly about the problem which you mentioned about the host DNA being over 99%. I'm just curious if you guys had looked at all at host depletion methods in your samples, and then as well wanted to know about how deep you sequenced to try to get to your microbial reads.
Yeah, great questions. So to the first question, that was the first 12 months of my project was figuring out, all right, how do we get rid of human DNA? And so we actually had a bunch of duplicate samples from the Begin study that we were able to use a couple different methods. And so Maria Nelson had looked at human depletion in sputum, and that's kind of where we started, and then used a couple of other methods like mechanical lysis that was uses ceramic beads and other detergent-based methods. And essentially what we found is there's no difference between the ability to get rid of human DNA, but all were very good at it. And so we had swabs that would be about, in the range of 60% human DNA to 90% human DNA. And with any of those methods, we could get it down to about like 5% human DNA. And the biggest difference was the more steps that you did to prep it, the more DNA you lose. And so what we ended up finding, which is a nice little control that we did, we added benzonase, which is an endonuclease. We treated it for 15 minutes, and then basically put it in. It did like a Qiagen extraction, and just that alone decreased the human reads down to about 5 to 20%, depending on the amount. And so we sequenced to 10 million reads per sample. And so with the amount of microbial DNA that was in there, we were pretty easily able to get down to the strain level.
Thank you.
Hi, Drake. That was really very interesting work. I guess I had a couple of questions around the LCI measurements. First of all, what reference values did you use? I mean, did you use like the GLI, the most recent GLI equation that came out? Because I was really struck at basically how low LCI was in general. I mean, it was like nearly normal in the group, and so even when you get a slight increase, you're not going to even that 3+ is like well within the normal limit.
Exactly. Yep. And so the reference that where I decided to put the hashed line was based on the ERS paper from 2020. And then this is what they, I think Dr. Pittman had kind of references too, that, a lot of these kids were already on modulators before. And so, are they already at a better state than, anybody that was not on anything prior? And so I think these kids are coming in a lot healthier than, those that would have been, several years prior. But yeah, I think it is really interesting. And, you're trying to tease apart different levels of normal, right? Yeah. And so one of the other ways that we thought about looking at this was, is there a difference between amount and then what is clinically abnormal and clinically normal, and kind of splitting it out that way.
Great, thanks.
We have a question in the app as well. Did you look at any associations between the gram-negative organisms and LCI? And the question writer acknowledges they recognize the numbers are small.
Yeah, so we looked at Stenotrophomonas because that was the only one that had enough pieces to do, the analysis on. And there was a significant association, and it's a little bit, and it's hard to say because there's, is an N of 8 out of 100, like almost 300 swabs. And so there was a relationship there, but it's just with a grain of salt because they were so low.
Can I? Pavel Drevinek, Prague. I'm just wondering about the swabs. We've got oropharyngeal swabs or cough swabs, and in some centers, including our center, we prefer cough swabs because of contamination from the upper airways, from the oral microflora, and the cough swabs showed us that there is a higher yield of the lower airways bacteria compared to the oropharyngeal swabs. So I'm wondering if there are any data or if you can comment on this, cough swabs versus oropharyngeal swabs.
Yeah, great question. And so there's what's written in the protocol and there's what actually happens. And so what's written in the protocol is that all of these kids, if they could they would try and get sputum first. And so if they'd spontaneously expectorate, they'd get that and then they'd swab. If they didn't spontaneously expectorate, they would induce or try and induce sputum. And so, these would all kind of fall into the category of cough swabs. We don't necessarily outside of knowing, we have data on which swabs there was sputum produced prior to that, but we don't have the super granular, details was there some deviation from the protocol? But the way that it was designed was to be a cough swab. All right. Anything else? Cool. Well, thank you for hanging out with us this morning. Again, we're going to all be down at the poster session, so come find us up here if you have any questions or down there. But thank you for your time and your attention. Have a good rest of your day.